everyone. It's Elizabeth with Hive Nurse. Welcome to Inside the Hive, the official podcast of Hive Nurse. We're here today at my house, inside my hive, to talk about all the things that are affecting nursing today. I'm going to throw it over to my partner, Ashley.
Hi, everyone. Welcome to Inside the Hive. We're glad you're here watching and listening. And we are very happy to introduce two very special guests that are going to help us break down some of the issues we're dealing with in nursing and in healthcare today. So I'm going to let you all introduce yourselves. Marlena, tell us a little bit about you.
Yeah, thanks. Marlena Gron. I've been a nurse for 12 years, and I am a nurse residency program director and nursing professional development specialist.
And Marlena is a repeat guest with Inside the Hive. So thank you, Marlena. Yes.
Happy to be here.
Yes, thank you very much. And Joel, tell us about you.
Yes, hello. My name is Joel, and I've been a nurse for 11 years. I currently work in the insurance side.
Oh, wow.
But I've also worked in med-surg, hospice, inpatient home side, and also have done behavioral health.
Oh, wow.
And so I see there's a lot of disconnect in the healthcare with kind of between the hospital, the home, and what resources can help the member out to succeed.
Yes. Well, thank you, Joel. And I feel like you bring such a unique perspective to what we're trying to really pull out of our guests and the work that we do is, you know, what are the problems that we're facing out there every day in real life? And then what can we do to fix it? So I love kind of the interaction between, we've got someone that's working in the hospital right now, really trying to grow our newest nurses. And we have someone on the insurance side, really trying to make sure our patients get what they need on the other side of it. So tell us what you're seeing out there. What are the problems that you see that face us all today?
A lot of the problems today seem to be miscommunication. We've got a disjointed system where the member, we call members in the insurance side, where the member goes into the hospital and then it's acute care. The hospital is putting a Band-Aid on and then they come home. Do they understand? Do they have the resources to go to their next appointment, the transportation? It's one of those, do they understand their discharge plan?
Yes.
And so there's a lot of what next? Do they fall through the cracks and then kind of come back to the hospital? And is there that communication between the case manager on the insurance side, the discharge planner, because sometimes the right hand's not talking to the left hand.
Yes.
Does the patient have that understanding of getting to their primary doctor? Do they have a primary doctor?
Yes.
Do they need challenges with food insecurity?
Yes.
Do they also have challenges with transportation, as I said? Maybe they need a counselor. Maybe there was a problem in the hospital, and if that's the case, then the doctor in the hospital can do a doc-to-doc with the insurance side with utilization to see, is it the right time for that member to go home?
Right.
Yeah.
Right.
All right. Well, I have a little bit of a hot take because I love nurse talk and I love social media. I'm a doom scroller till the end of time. And there is a ton right now about there's a lot of popular content about sort of the insurance companies and how evil they are and how bad they are. So you're a nurse on the inside of insurance companies. So tell me a little bit about some of the things that you do for patients to ensure that they get the things they need, right? You just talked about a lot of the social determinants of health.
Sure. The insurance company sometimes is thought of, oh, we're the evil ones. Well, we're actually kind of the ears, for the patient when we make those phone calls. I remember one time I had a member that was having a stroke on the phone. And she did not know what to do. And I said to the person on the phone, can you call 911? No, could not call 911. I kept her on. I called the 911 operator and stayed there for 15 minutes.
Emotions.
And so, so it's kind of one of those that was a win. And then 2 months later,
you saved her life. That's like beyond a win here.
And that's from the insurance side. I mean, Joel, we have no idea that any of this goes on. And I'm thinking about these new graduates that you're putting in there. Do they know any of this stuff that goes on?
No,
on the
not at
outside.
all. And it's funny that you bring that up because I was just thinking how much it's focused on the social determinants of health. For the new nurses, we call it social factors of health. It's a little easier for them to kind of to absorb, but we've had to learn how to break it down for them in even a course talking about, when you're in nursing school, so much of what you're being taught about social determinants of health. And it's such a big picture for when you are in a role like case management or in that type of field where when you are an inpatient nurse at the bedside, it's really hard for them to apply that concept of how can I on a daily basis make an impact on those social determinants of health. And so we've had to learn how to break it down to say, are you asking the right questions to elicit the right answers so that your documentation reflects what it needs to for the case managers,
And then ultimately for insurance companies.
Absolutely.
Well, and also for the patient
Yep.
too.
Yes.
Everyone knows that I'm a nurse practitioner and I practice actively. And I had a patient, I treat a lot of eating disorders. And so I had a patient that was treated for an eating disorder. She went in inpatient in the hospital. She used a lot of resources, right? She spent time at a residential facility, and then I was seeing her for follow-up. And I saw her every 2 weeks. Like, it was great. Saw each other every 2 weeks. She was progressing. She was doing really well. And what I noticed was this pattern of, like, towards the end of the month, she would start losing weight again. And I was like, what is going on here? Like, what is the deal? Like, she does great for 2 weeks, and then for 2 weeks, she kind of falls off the curve. And every time I ask about social determinants of health, every visit I ask, do you have enough food at home? We have a food pantry in the clinic, et cetera. And it took this patient about 6 months before she was comfortable telling me that she actually did not have enough food at home, that her mom was on SSI disability. And so they got their, first of the month, they got their sort of allotment of resources. And after about 2 weeks, she would purposely restrict because she wanted to make sure her little brother was getting enough food. And so I brought her in every week to clinic to follow her. And I had her come in and access our pantry. We even made sure that we had all of the things that she loved in the pantry so that she could take home 2 bags of groceries. And once we were able to get her connected with the resources that she needed, she, everything resolved. And so this was actually like a true overutilization of resources if we had just been asking the questions the right way. Yes. So when you're talking about those new grads, learning how to be very sensitive on those topics and learning how to ask those questions is so key for those patient outcomes.
And observation, what a keen observation that you made that you didn't have to make,
Oh yeah, totally.
Yeah. Joel, what would you tell the new grad nurse that Marlena is bringing on? Because you've been on both sides.
Sure.
So if you were back to the bedside today, what would you tell them to do differently so that they can really engage with their patients better before they get discharged?
The first thing is that don't be at your laptop typing away.
Yes.
That's the first thing.
Yes.
Build that rapport with that member. Maybe if there's a family member in the room, having a joint, hey, can we talk with your mom, dad, uncle, whoever it is, get that, authorization. But yes, nurses at the bedside, especially new nurses, go 1, 2, 3, 4, 5. You have to build that rapport. You have to build that discussion and see where it takes. So if you have that person where they're having challenges with food, then what's going on? Is it a problem with, maybe it's an elderly person and it's the teeth? Maybe
I don't even think about that. I'm a pediatric nurse practitioner. Yeah. All my patients have teeth. Except for the newborns.
Yes.
But it's kind of one of those, have that dance with the patient, I'll call it patient now, to find out what are their needs.
Yeah.
And yes, the determinant of health, are they able to get to their appointments? The insurance company can help with transportation.
Right.
And so many people don't know that.
Yeah.
So many people do not know, especially if the patient's on Medicaid, about Medicaid transportation. And I have patients that come from all over the state to see me. And, I'm like, the first thing I do, I'm like, here's the number to call to get transportation. Like, don't let transportation be the reason that you can't come to the clinic.
Yeah.
Or maybe they've got challenges with depression.
Right.
And so then they can get help. Do they know 988? The hospice cap in me is also that serious illness conversation. And so I think sometimes if that brand new nurse can sometimes shadow a hospice nurse, then that can kind of build a little bit, because hospice nurses were so used to kind of going with the flow.
All those conversations.
And the conversations just shift.
What an interesting idea to have new grad nurses connect with hospice nurses on communication techniques, not on the topics, right? But just on like, how do you elicit this information from patients?
Yeah.
Yep. And I love what you talk about with, putting down the computer and asking the questions. So much of the advice that we give, our new nurses in those settings when they're asking those questions, especially around discharges, is just the simple statement of "tell me more." So instead of just stopping when they say, no, I'm not able to work out, it's, well, instead of just handing them the pamphlet of what they should be doing and what our discharge instructions are encouraging, it's tell me more of why you're not doing that. Is it the home? Is it your environment? Is it your lack of access? Because so often when you ask that extra question of tell me more, or, can you tell me a little bit more about how that happened? That's often when we get to those answers that can then help with building that true solid discharge plan.
Yeah.
Well, and let's call out, we like to call out the hard parts here too. So let's call out the fact that today's environment has not really become a conducive environment for communication.
Absolutely.
I mean, we work with people that can't even make eye contact because they don't even know how to do that. And we actually get the opportunity to talk with a lot of students and a lot of new graduates who say, I'm just a taskmaster. I'm just trying to figure out how to keep my head on straight. I don't have time to have these conversations. And so I almost think we have to look to our organizations to really think differently about the environments they're bringing people in. And maybe once they're through that orientation phase, put them back in a communication orientation. Put them with the hospice nurse. Put them with case manager. Just let them absorb how to have a conversation with an elderly person. Because I mean, and look at how
or with a toddler.
Yeah, or with a child. Because look at how isolated our world has become. And even those patients that end up in the healthcare setting, in the hospitals, in hospice, they haven't talked to people either. I mean, we've just cut off communication. So I think we really have to think differently about strategies for our newest team members.
I think there's another problem too, is that in the hospital, you really focus on, you see that person now, and you don't know what the home environment is.
Yeah.
And so the hospital is put a Band-Aid, fix the problem, get them out the door.
Yep.
And so it's not really designed to how can there be more support in the home. Like when I started with the insurance side, I work as the telephonic side. So I've only done that for 5 years.
Okay.
But we would have, from the insurance side, providers that go to the home.
Okay.
The other thing is sometimes there would be a triage line. So if a member's having a problem, they call that number.
Okay.
And just like the hospital would have a triage also. But I think the hardest part the hospital has is that, like you said, to be able to see the different sizes. I love the case manager. I've done the discharge planning work at Wake Med.
Yeah.
And the biggest thing that a case manager discharge planner does is they have to see what's happening for the patient, what's happening with the doctors, what's the next step, and having that open communication with the nurses. If the nurses can understand the different roles of the physical therapist. Let's take that, for example. A physical therapist, they're going to look at what type of therapy may that individual need. Can they go home? Do they need to go to a skilled nursing facility? Or how many times do you have a stroke patient? And now Medicare's got guidelines. Insurance companies have guidelines to say if you're in acute rehab at the hospital, that you have to be able to do so many hours of rehab a day.
Yeah.
The problem is that so many people come to the hospital and they say, I want my loved one to go to Wake Med acute rehab.
Mm-hmm.
But do they meet medical necessity? That's a whole nother.
Yes.
And so that's the problem
Yes.
where sometimes
Those are the hot takes.
those are the hot takes
Mhm.
because how do you look at to the family, to the member to say, I'm sorry, you don't quit that criteria for X, Y, and Z reason, but you fit this as an option.
Yeah.
Yeah.
You know, it makes me think that we don't have enough cross-pollination between our
That's
insurance
true.
companies
Yeah.
and our
Cross-pollinate.
providers. And we've created this wall, right?
Yeah.
Yeah.
And we have to open that up. I mean, I think
Yeah.
this is the
is what
first
the
time
Hive is
I've
all
talked
about.
to an insurance person about anything, and just your insight. And I don't know if all insurance companies have all these nurses like you, Joel, but I just feel like we have to start navigating this together, because too many times now I hear physicians say, oh, I can't deal with, or nurses, I can't deal with insurance anymore. I'm just getting out. Well, how about we try and fix it together? And obviously money's at the other end. We're never going to change that. It's a business, right?
Do you know what one of my biggest challenges with my job is? I'll call that discharge planner, and that discharge planner that's handling that member, they won't call me back. So how can I help?
If you can't talk
Now I will call that discharge planner and call the member, but if that discharge planner doesn't partner up, then they're just out. And then we have to do our assessment, which is those determinants of health. And then do they have medication? Do they need, I've had cases at home also with the Spanish speaking population. I've had situations where I'll call the member on the language line in Spanish, and they can't in North Carolina communicate with the primary doctor office. So sometimes I'll use my interpreter to have me and the interpreter call the primary doctor to bridge that gap. We have too many gaps.
Insurance is not all evil. Not everyone who works for an insurance company is trying to make you do more prior auths. They're trying to help the patient or the member.
Which I love that term, by the way.
Yeah.
It's so nice.
Well, it's interesting. When I went from the insurance member to the hospital at Wake Med, I had to switch back to patient.
Yes.
And then when I switched back to insurance, then it was member again.
Yes.
And it's so...
But language matters.
It does. It does.
Well, this has been really a cool conversation. And I think one we'd like to explore more. I do too. Thank you, Joel.
Yeah, sure.
And Marlena, I think you have your work cut out for you now to add to your competency development around what goes on in the home. I mean, that's an easy question for these nurses to learn how to ask.
Bridging the gap from the hospital to home.
Yeah,
I love it.
Definitely.
I love it.
Well, thank you guys for joining us at Hive Nurse. Remember, you can earn continuing education by logging into your member account on Hive Nurse, looking for that podcast, listening to the podcast, and then doing the quick quiz, and you can earn an hour of CE for listening to this podcast today. Please follow us on all the things. We have TikTok, we have Facebook, we have Instagram at Hive Nurse, and we can't wait to see you again. Bye.
Bye.